Meeting to order. So welcome everyone to meeting number 24 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the second wave of the COVID-19 pandemic. We'd like to remind everyone that everyone has the right to participate in these proceedings in the official language of their choice. In the event that there is a difficulty in hearing translations, please bring it to our attention as soon as possible so that the matter can be resolved. So I'd like to welcome the witnesses at this point. From the National Advisory Committee on Immunization, we have Dr. Caroline Quashtan, Chair and Professor at University of Montreal. With the Department of Health, we have Dr. Marc Berthiaume, Director, Health and Food Branch, Therapeutic Products Directorate, Bureau of Medical Sciences. And with the Public Health Agency of Canada, we have Ms. Kimberly Elmsley, Vice President, Immunization Branch, Dr. Howard New, Deputy Chief Public Health Officer, and Dr. Guillaume Poliquin, Acting Scientific Director General, National Microbiology Laboratory. Just advise the speakers that I will be using these cards to indicate that your time is almost up. I will typically put them up about 1 minute before your time is up, and I will use this when your time is up. And if you see that, please wrap up in due course. So with that, we will carry on with our presentations. We will start with Dr. Caroline Quashtan. Doctor, if you please go ahead, 10 minutes.
Thank you very much. Alors, Monsieur le Président.
Mr. Chair, members of the Standing Committee on Health, I'd like to thank you for inviting me back to testify before your committee, this time to talk to you about the use of the AstraZeneca vaccination for adults aged 65 and over. The NACI recommendations issued on March 1st, 2021 are as follows. A complete series of the vaccines against COVID-19 currently approved should be suggested to people belonging to the authorized age group without contraindication. Given the limited supply of vaccines, the initial doses of the vaccine should be reserved to those key populations outlined in NACI's guidance on the prioritization of initial doses of COVID-19 vaccines. Due to the suggested superior efficacy in clinical trials, the mRNA COVID-19 vaccine is preferentially recommended for individuals in the authorized age group without contraindication, especially those at the highest rate of severe illness and death and highest rate of risk of exposure to COVID-19. In the context of limited supply, the AstraZeneca COVID-19 vaccine may be offered to individuals aged 18 to 64 without contraindication. The advantages of early vaccination outweigh the limitations of a vaccination with a less efficacious vaccine. The ease of transport, storage, and handling of this vaccine facilitates access to vaccination, which may otherwise be challenging, and informed consent includes discussion of current vaccine options and the timing of future options.
In Scotland by Vasiliou and colleagues, entitled Effectiveness of First Dose of COVID-19 Vaccines Against Hospital Admissions in Scotland, National Prospective Cohort Study of 5.4 million people, which is a preprint, which means that it is not yet reviewed by peers. Data from an ongoing phase 3 trial in the US are not yet available. Of note, the FDA is waiting on these results to make a decision on authorization. The clinical trials data submitted were challenging to interpret as there were use of both a low-dose standard dose and a standard dose vaccine regimen in trials, as well as varied interval between doses, and as the recruitment of progressively older study participants after the initial focus was put on adults 18 to 55 years. The estimates of vaccine efficacy against confirmed COVID-19 cases occurring at least 15 days after dose 2 by dosing interval suggested an increase in vaccine efficacy with increasing interval between doses of vaccine, but confidence intervals are wide and overlap. Just as a recap, A 95% confidence interval means that we are 95% confident that the true value, in this case vaccine efficacy, will fall within these boundaries. When confidence intervals around a point estimate overlap in a given study, it means that the two estimates could possibly be the same. In this case, the vaccine efficacy with a dosing interval of 4 to 8 weeks was 55.7%, with a 95% confidence interval going from 39 to 68, while the vaccine efficacy of an interval greater than 12 weeks was 81.6%, with a 95% confidence interval from 47 to 94. So both intervals are overlapping. A subgroup analysis of vaccine efficacy against the first occurrence of confirmed COVID-19 at least 15 days after dose 2 showed that for all studied intervals between doses, the point estimate for vaccine efficacy ranged around 60% for the younger age group, so that means 18 to 64, with a confidence interval that did not include 0, which means a vaccine efficacy is really there, compared to 43% in the 65 years and over, with a wide confidence interval that includes 0, meaning that the actual vaccine efficacy could be null. Based on these data, NACI felt that it was safest, given the availability of 2 other mRNA vaccines that were highly efficacious in people 65 years and over, to recommend the mRNA vaccines in that age group and not recommend the AstraZeneca vaccine in the 65 years and over, awaiting further data, including the clinical trial that is ongoing in the US. NACI also reviewed the Scottish paper as these data were available. This study, which has not yet been peer-reviewed, is a real-time prospective observational cohort with a national level coverage in Scotland using administrative data that are all linked. The cohort included 5.4 million people. The authors studied the first doses of either the Pfizer-BioNTech or AstraZeneca vaccines. The authors assessed the effectiveness, so effect of the vaccine in real life by opposition to efficacy, which studies the effect in a randomized clinical trial, against hospital admission with COVID-19 as the main diagnosis within 28 days of a positive PCR for SARS-CoV-2. During the study period, 35 of participants were vaccinated, mainly among the first priority groups, age 80 years and over. Younger individuals had a higher uptake of the Pfizer vaccine, while the 80 years and over had a higher uptake of the AstraZeneca vaccine. The authors reported a statistically significant adjusted vaccine effectiveness against COVID-19 related admissions in those who received a first dose of either vaccine that increased over time until a peak at day 28 to 34 post-vaccination. Although these data seem promising, the committee was not able to explain why the vaccine effectiveness was so high so early on. On days 7 to 13, the reported effectiveness was already 70%, with a 95% confidence interval from 63 to 76. This raised questions about the study methodological validity. Moreover, given the context of the targeted vaccination and study design, NACI considered that there was a high risk of bias and that vaccinated individuals were likely not comparable to unvaccinated individuals. Given these uncertainties, NACI decided that this study was not solid enough to change policy and kept its recommendation not to use the AstraZeneca vaccine for the 65 plus at that point in time. In the short time since NACI's recommendations were published, 2 other real-world effectiveness studies have been pre-printed, and the committee met yesterday on March 10th to discuss them and decide if these new data will change recommendations. An updated statement that will include the real-world evidence will be released as soon as possible. En ce qui a trait à l'autorisation de santé.
As regards Health Canada approval, it's important to understand that while Health Canada and NACI do report to the Minister of Health, there is no reporting relationship between the two. Health Canada has a mandate to approve the particular indications of use of a product that must be safe, immunogenic, effective, and of appropriate quality. To do so, it reviews preclinical data, clinical trial data, and the information provided by the manufacturer. Once a vaccine has been approved, NACI steps in. NACI is both a technical committee and an advisory body, and its objective is to recommend vaccination strategies to promote health, prevent and control infectious disease, and prepare for public health emergencies or intervene should the case arise. To do so, it reviews all of the relevant accessible evidence pertaining to the vaccinations from a public health perspective. It then makes it considers the characteristics of the vaccinations and the burden of the disease, but also the issues of ethics, equity, acceptability, and feasibility. It uses mathematical modeling, which enables it to look at the impact of various strategies. NACI then can make off-label recommendations if there is a clear need backed by an ethical analysis.
Advantages of administering a COVID-19 vaccine earlier to Canadians against the limitations of administering a vaccine that, based on available data, is less efficacious. Based on mathematical modeling, various strategies were studied. In clinical trials, mRNA COVID-19 vaccines demonstrated higher efficacy than the AstraZeneca vaccine. In the context of limited supply, NACI, however, considered additional factors when assessing options for COVID-19 immunization. Internal modeling reviewed by NACI based on Canadian supply projections indicated that a program including both mRNA vaccines and AstraZeneca COVID-19 vaccine could have short-term public health benefits, preventing symptomatic disease, hospitalization, and death when the AstraZeneca COVID-19 vaccine is offered earlier to adults 18 to 54 instead of waiting for mRNA vaccine during periods of epidemic transmission. The public health benefits of offering the AstraZeneca vaccine earlier only to individuals 55 to 64 years were less certain given their shorter expected wait times to get mRNA vaccines. Modeling assumed no impact of vaccines on preventing transmission, as evidence of this is not yet available. A population that receives a lower efficacy COVID-19 vaccine will have protection against COVID-19 disease earlier than if they had waited for mRNA vaccines to be available. However, these populations may ultimately have lower protection depending on the duration of protection of both vaccines, as a larger proportion of the population will remain susceptible. Depending on vaccination strategies, this could potentially exacerbate health inequities if this potential harm is not considered when implementing the vaccine program in populations who experience intersecting risk factors for severe disease and exposure. Yet the mRNA COVID-19 vaccines have more challenging storage and transportation requirements than the AstraZeneca COVID vaccine, which may limit the venues where the vaccine may be offered. Vaccine hesitancy may be reduced by offering the COVID-19 vaccine in more convenient locations. That element was deemed important in the decision as to who should receive the AstraZeneca vaccine. J'espère que ces explications ont permis au comité de comprendre.
I hope that these explanations will enable the committee to understanding the underlying thinking of NACI with respect to its decision-making process and recommendations issued on March 1st. Thank you very much. I'd be pleased to answer your questions.
Thank you, Dr. Quashtan. We'll go now to the Department of Health. Dr. Mark Bertium, Director, Health and Food Branch. Please go ahead. 10 minutes, please.
Good evening, Mr. Chair. My name is Dr. Marc Bertium, and I am the Director of the Bureau of Medical Sciences at Health Canada, Health Products and Food Branch. Thank you for inviting me to appear before the committee today. I appreciate this opportunity to discuss Health Canada's high standard for the vaccines approval process, and in particular, address questions regarding the approval of the AstraZeneca vaccine for people over 65 years of age. I want to begin by emphasizing that Health Canada authorizes vaccines only if they meet the department's stringent safety, efficacy, and quality requirements. As with the other vaccines, Health Canada conducted independent and thorough scientific reviews to determine that the benefits outweigh the risks for the AstraZeneca COVID-19 vaccine, which was developed in partnership with Oxford University, as well as the Serum Institute of India's version of the AstraZeneca vaccine sponsored in Canada by Verity Pharmaceuticals Incorporated. Health Canada has rigorously evaluated the data available from clinical trials and real-world evidence and determined that this vaccine is safe to be administered in adults 18 years of age and older. We also collaborated with the European Medicines Agency on the review of the AstraZeneca vaccine as part of its open process. This initiative makes it possible for trusted regulatory authorities outside of the European Union, such as Health Canada, to work together and share information throughout the review process. All regulatory authorities that have authorized the AstraZeneca vaccine have granted unrestricted adult indications. Even though limited information from clinical trial is available to calculate its efficacy in people 65 years of age and over, Health Canada's authorization for a broad adult population has taken the available data on immune responses into consideration, and there is emerging promising evidence that is beginning to be reported from studies on the real-world use of the vaccine, along with data on the safety profile of the vaccine from millions of people who have received it. In addition to the encouraging real-world evidence that is already showing benefits with respect to outcomes such as hospitalization, it is important to note that there were no safety issues in this age group, either in the clinical studies where about 700 people over the age of 65 were administered the vaccine, nor in the large numbers of seniors who have been vaccinated to date in other countries that have also authorized the AstraZeneca vaccine and are administering it in people over 65. Specifically, during the first summary of safety reporting period of January 1st, 31st, 2021, safety data was available for over 3.7 million people who received the vaccine with no safety issues identified. A safety signal of anaphylaxis has more recently emerged, which is currently being added to the product monograph. Health Canada is aware of the report in Europe of international regulators working closely with the national regulators to gather information, including the European Medicines Agency, whose safety committee has initiated an accelerated investigation. At this time, we do not believe that this is a new safety issue that will impact the deployment of the vaccine in Canada, but these sorts of events demonstrate how our rigorous safety system works well to identify and quickly start to investigate issues. Health Canada is reassuring Canadians that the benefits of vaccination outweigh the risk. We expect further information from ongoing clinical trials and post-market monitoring in the coming months, and if there are additional changes required with regards to safety or efficacy, Health Canada will take the necessary actions. In the meantime, the department has been transparent regarding the data that was considered and has reflected the limited data on efficacy for those over 65 in its regulatory documents, including the product monograph. Je tiens à souligner que tous les vaccins
I would note that all COVID-19 vaccines have been authorized in Canada under an interim order approved in September 2020, which allows us to expedite the review of treatments and vaccines for COVID-19 while maintaining a high level of scientific scrutiny. Through this interim order, Health Canada is able to approve new vaccines based on available evidence with more agile administrative and application requirements. It also allows for rolling reviews, which lets a vaccine manufacturer submit their request for authorization before they have completed all the clinical trials. This means that they can submit required data as it becomes available. Moreover, the interim report provides Health Canada the authority to apply terms and conditions to require the manufacturer to continue providing information on the safety, efficacy, and quality of the vaccine once marketed. We also have a strong post-market safety surveillance system to monitor the safety of COVID-19 vaccines. Once a vaccine is on the market, Health Canada and the Public Health Agency of Canada monitor for any adverse events after immunization, in collaboration with the provinces and territories, international partners, and the manufacturers. Under the interim order, terms and conditions may be imposed on any authorization at any time, such as conducting additional assessments of safety information. We will take prompt action if any safety issues are identified. All of Health Canada's regulatory decisions are independent and based solely on science and evidence. Our dedicated review teams for COVID-19 vaccines are comprised of experienced regulatory and scientific experts, including scientists and physicians with many years of experience reviewing vaccines. Together, these measures have allowed Health Canada to authorize several clinical trials in Canada for COVID-19 vaccines, as well as 5 vaccines: Pfizer, BioNTech, Moderna, AstraZeneca, the version of AstraZeneca manufactured by the Serum Institute of India, and Janssen. As part of our continued commitment to openness and transparency, Health Canada has published detailed information about the authorized COVID-19 vaccines on the department's COVID-19 Vaccines and Treatments portal, including Canadian product monographs and regulatory decision summaries, which provide a high-level summary of the evidence that was reviewed to support the authorization of the vaccine. Health Canada and the Public Health Agency of Canada also provide weekly updates on reported adverse events following immunization. Our response to the pandemic is being guided by the latest science and research. We also continue to monitor the emerging viral variants closely and work with manufacturers and international regulators to assess the impact of the new variants on a vaccine efficacy and provide guidance to manufacturers. Health Canada, as part of the Access Consortium, which also includes our regulatory counterparts in the United Kingdom, Australia, Switzerland, and Singapore, has collaboratively developed and published guidance for industry on our common regulatory approach to authorizing updates to existing vaccines to address strain changes. Canadians can feel assured that the review process for each vaccine was rigorous and that there are systems in place to continue monitoring the safety and efficacy of COVID-19 vaccines after authorization. Vaccines are critical to Canada's pandemic response and our fight against COVID-19. The authorization of these additional vaccines that meet Health Canada's rigorous safety, efficacy, and quality standards provide additional tools to fight this pandemic as quickly as possible. Thank you for this opportunity to speak with the committee today, and I would be happy to answer any follow-up questions you may have.
You are on mute, Mr. Chair.
There you go. Merci, Dr. Bart.
Thank you, Dr. Bertillon.
Agency of Canada. Public Health Agency will have collectively 15 minutes to speak. We'll start with Ms. Elmsley, Vice President, Immunization Branch. Ms. Elmsley, please go ahead. So, Ms. Embley, we can't hear you. No, still can't hear you. Maybe we'll suspend for a couple minutes and sort this out. Meeting suspended. Ms. Emsley, please go ahead. On behalf of the Public Health Agency of Canada, 15 minutes, please.
Thank you very much, Mr. Chair, and good evening, members. My apologies for the technical difficulties. This evening, I will be speaking about the role of Canada's National Advisory Committee on Immunization in the immunization system in our country. NACI, as you know, is an expert external body that provides independent advice to the Public Health Agency of Canada on the optimal use of authorized vaccines in Canada. NACI has been operating for over 50 years as the country's national immunization technical advisory group and is widely respected by provinces and territories and internationally. The committee is made up of experts from across Canada in the fields of pediatrics, infectious diseases, immunology, pharmacy, nursing, epidemiology, pharmacoeconomics, social sciences, and public health. In the context of COVID-19, Canada's federal, provincial, and territorial governments utilized the advice of NACI as the authoritative body on pandemic vaccine prioritization and vaccine public health program design. Its recommendations are designed to support the pandemic public health response goals of reducing serious illness and overall death while minimizing societal disruption as a result of COVID-19. NACI's COVID-19 advice is focused on the strategic prioritization of vaccines and specific vaccine guidance and ranking of products for clinical use. Recommendations inform federal, provincial, and territorial governments planning for the efficient, effective, and equitable allocation of COVID-19 vaccines. NACI thoroughly reviews available evidence when developing its recommendations. This includes the consideration of vaccine characteristics such as safety, efficacy, immunogenicity, and effectiveness. NACI also incorporates programmatic factors such as economics, ethics, equity, feasibility, and acceptability. NACI's guidance is advisory in nature. Immunization program planning and delivery decisions fall under the provincial and territorial jurisdiction. The provinces and territories ultimately determine how to use authorized COVID-19 vaccines based on jurisdictional needs and circumstances, including local epidemiology, public health considerations, healthcare system capacity, and vaccine management logistics. NACI is supported by a secretariat that is housed within the Public Health Agency of Canada. While NACI members are not government employees and remain external to the federal government, the Secretariat supports committee meetings and deliberations, the rigorous scientific review of evidence, and the development of NACI statements and communication products for healthcare providers and the public. The Secretariat support is necessary as the committee members are volunteers, holding important full-time clinical and public health roles. NACI complements the expertise of its broad membership by conducting extensive stakeholder engagement when developing its recommendations involving many liaison organizations. The Canadian Immunization Committee, which is a federal, provincial, and territorial table, is actively involved at multiple points in NACI's work. When drafting guidance on COVID-19 vaccines, including the AstraZeneca vaccine, NACI sought input from the Special Advisory Committee on COVID-19, which is made up of provincial and territorial chief medical officers of health and other senior officials. There is an important distinction to be made between NACI's role and Health Canada's function as Canada's national regulator. It is not uncommon for NACI to provide recommendations that are broader or narrower than the conditions of use approved by Health Canada. NACI is different from Health Canada, which does not dictate practice of medicine or make recommendations on how vaccines should be used in different age groups and subpopulations for public health impact. In keeping with its mandate to optimize the public health benefits of immunization in Canada, NACI has historically provided preferential recommendations on the use of vaccines in key populations for diseases. Some examples include influenza and shingles vaccines. In making its recommendations, NACI also takes into consideration other vaccines available in Canada and may make preferential recommendations based on the current context. This is different from Health Canada as the regulatory authority, which reviews each vaccine independently to assess if there is sufficient evidence of safety, efficacy, and manufacturing quality to meet regulatory requirements for authorizations. Clinicians are very used to consulting both the product monograph and NACI advice when making their clinical vaccine decisions for patients. They do not expect these to be identical, understanding that they are driven by different perspectives. NACI's recommendations complement regulatory indications with real-world context and with information on public health strategies based on available and evolving evidence. The committee revises their recommendations when needed based on new evidence as well as the evolving context. On the global stage, other countries rely on their respective national immunization technical advisory groups for COVID-19 expert advice. Through the NACI Secretariat within FAC, NACI is very well connected with international advisory committees of this type. In fact, Canada is currently the chair of the Global NITAG Network, a World Health Organization supported forum where national technical advisory committees on immunization share information and collaborate on work plans. The NACI Secretariat is also in regular contact with countries bilaterally and through the global NITAG network to stay up to date on international COVID-19 developments. FAC expects different approaches to be adopted around the world in response to COVID-19. Every country develops immunization programs that are informed by local epidemiology, values, preferences, social infrastructure, and healthcare systems. Naturally, these considerations vary significantly by country. As you are all aware, real-world evidence on COVID-19 and vaccine effectiveness is evolving in real time. NACI continues to closely monitor and review this emerging evidence and will revise its recommendations as information becomes available. I would like to thank the committee chair and members for the opportunity to address this committee. Thank you.
Thank you, Ms. Emsley. Is there anyone else from the PHAC that wishes to speak as well?
There is no one else speaking at this time, Mr. Chair.
Great, thank you very much. In that case, we will begin with our questioning. We will start with Ms. Rempel-Garner, please, for 6 minutes.
Thank you, Chair. I think it's Dr. Berthoum from Health Canada. Does Health Canada have any concerns that any age group or demographic is at an increased risk of pulmonary embolism or DVT after receiving a dose of the AstraZeneca vaccine?
Thank you for your question. There is an ongoing investigation in Europe about thromboembolic events. They are thought to be potentially related to some lots, but more needs to be found. At this point, there's no concern in Canada about the potential risk for thromboembolic adverse events with the AstraZeneca vaccine. I could add as a complementary piece of information that in the UK, where 11 million doses of AstraZeneca vaccine were administered, there were no safety signals of thromboembolic events that was identified.
Thank you. Dr. Quashtan, Dr. Berthoum spent most of his presentation talking about the safety of the AstraZeneca vaccine, but it's my understanding that your recommendation against vaccinating or using the AstraZeneca vaccine in seniors was related to efficacy. Is that correct?
You are correct.
Okay. So with the other vaccines that have been approved in Canada, the two mRNA vaccines, as well as Johnson & Johnson, do they have higher efficacy standards or higher levels of efficacy for age 65 and older?
So if you look at the two vaccines, the mRNA vaccines, the efficacy is actually close to 95% for the 65 and over. For the Johnson & Johnson, NACI hasn't yet reviewed all the data, so our recommendation is not out yet, but we do have data on the 65 and over that are statistically significant, meaning that the 95% confidence interval does not include 0.
Okay. You in your comments, you had talked about making decisions within the context of limited supply. Do you think that the lack of vaccine supply in Canada to date, coupled with the threat of variants, played into the government's decision to approve the AstraZeneca vaccine for age 65 and older in spite of your recommendation?
I think you would have to ask Health Canada the exact reasons.
Dr. Berthoum, I'll ask the same question to you. Did the lack of supply or limited supply of mRNA vaccines play into your decision to ignore NACI's advice?
No, it did not. The Health Canada based its decision on a number of elements. There was evidence of immunogenicity, so like people over 65 in immunogenicity studies were building antibodies when administered this vaccine. The paucity of the data is related to the small number of people that were in clinical trials that were 65 and over. So there is, and that's reflected in the product monograph.
But all else considered equal, what we've just heard is that the mRNA vaccines are more effective for age 65 significantly than AstraZeneca. So why did Health Canada not recommend prioritizing the Pfizer vaccines for that age group and AstraZeneca and other age groups where there's a higher level of efficacy?
So if you would make a comparison, for example, with antibiotics for pneumonia, so Health Canada would approve a set of antibiotics for pneumonia, but would not necessarily say this one is better than this one. So then it comes into the practice guidelines of different experts that will kind of guide the clinical decision making. So,
but in this case, with limited supply and the economy in lockdown, wouldn't Health Canada be looking at, and the variants obviously being a threat, wouldn't Health Canada be well advised to consider the most vulnerable population in a prioritization recommendation for vaccines?
So Health Canada's strategy is to have like a portfolio of vaccines that offer different characteristics. For example, the AstraZeneca vaccine has one characteristic that's very interesting that the others don't have, is that the vial, once you take the first dose, can be refrigerated and used for other patients for up to 48 hours, while all the three others, it's only for 6 hours. So with such let me finish, please. So with such
I have very limited
property,
time. I only have a minute and a half left.
Okay, sorry.
You can table that with committee if you'd like, although none of your colleagues tend to do that on a regular basis. But with the minute that I have left, you and other officials from the federal government have said that it's the province's decision on whether or not what advice to take, essentially. Are you not concerned that a balkanization of vaccine recommendations across Canada would potentially lead to vaccine hesitancy or people in age 65 and older withholding getting vaccinated, given the lack of clarity and advice from the federal government?
I think that's a question for my FAC colleagues.
Go ahead.
Thank you very much. Maybe I'll start on that one. So in the context of the vaccine strategy and the need to ensure there is a diverse strategy and availability of vaccines across the country, what's important is that we're getting vaccines to the provinces and territories, and they're getting effective vaccines.
Are you concerned at all about vaccine hesitancy due to the confusion in advice?
We have been providing clear advice to Canadians through the work with the provinces and the territories, and we'll continue to do that.
By what stretch does conflicting advice mean clarity?
So there will be advice that changes over time. That is exactly what is happening as science becomes clearer, as more studies are reading out their results. We can expect to see changes in advice, and it's really important to continue to provide as much information as clearly as we can and recognize that will change and inform the public that things will change as evidence changes.
Thank you, Ms. Rempel-Garner. We'll go now to Ms. Sadhu. Ms. Sadhu, please go ahead, 6 minutes.
Thank you all the witnesses for joining us today. I know that you have all been working very hard for all Canadians. Thank you very much for that. Mr. Chair, by the end of the month, we'll have 8.5 million doses of COVID vaccines. And by July, we have a 36.5 million vaccine doses. And this does not even include one from Johnson & Johnson. My first question is to Dr. Quach. A lot of Canadians are listening, and some data presented by the experts may be complex to understand. In simple terms, based on all the data you have considered, how effective is AstraZeneca?
So in terms of efficacy, it is 60% efficacious for the 18 to 64 and approximately 40% efficacious for the older population. However, when you look at effectiveness, it seems to have a 70 to 80% effectiveness in preventing hospitalizations and death, which is comparable to the other vaccines. These are real-world data, which are not of the same high standard quality as what we usually see in randomized controlled trials, but they are the data that we will have, moving forward with the rollouts of the vaccines, and that's what we are also looking at. So in terms of preventing complications, it's good.
Thank you. And Dr. Quach, is the sake of the clarity, do you think the Canadians should choose to wait for a specific vaccine, or should they take the first one that is offered to them?
At this point in time, I think that whatever is offered to you, you take, because the risk of catching the infection is now, while the transmission in the community is high. If you wait out till June or July when your turn comes for the mRNA vaccine, for instance, it means that you're still at risk for infection until then. And our hope is that the Canadians that are most vulnerable to infections and complications will be able to get vaccinated as quickly as possible.
And Dr. Bertium, can you tell us about the data that Health Canada considers when it makes recommendation for who is eligible for vaccine? Obviously, you examined the clinical data that came in on a rolling basis. Do you take in information from any other sources?
When we examine a submission, like for the AstraZeneca vaccine, we evaluate based on the data provided by the sponsor. So for this specific submission, the sponsor provided the data from 4 clinical trials, 2 of which were more like important in terms of the analysis, and they also provided the Scotland real-world evidence data as part of the evidence to consider for the approval of their vaccine.
Thank you. As we know, NACI recently advised the second dose could be effectively administered with the longer gaps. To any of the witnesses, our extended COVID-19 vaccine does a particular concern for any particular population or groups?
So I guess I can get started on this one. In terms of the extended interval, the most vulnerable in long-term care facilities, for example, are probably the group in whom we wouldn't be extending. The reason why NACI didn't put that out explicitly was because when we spoke to our counterparts, the provinces and territories all said that most of their population were already vaccinated. However, when we look at data provided by Quebec, BC, and the UK, we see that up to 8 weeks, even in those very fragile population, we still have a vaccine effectiveness above 80%, which does not seem to be declining over time. And that was one of the bases on which that recommendation was made.
And thank you. With all of that being said, do you think that these recommendations that we have discussed will put any Canadians at risk?
I think what you have to look at is really a risk benefit, as you're saying. So what we are aiming for is to try and get as many Canadians vaccinated with the first dose with an overall effectiveness of approximately 80%, which then can help control the pandemic and decrease the impact of variants on that transmission. Of course, if we had plenty of vaccines and we were able to give the vaccine quickly, we would not be trying to extend that interval. I think that this interval is also something that is of limited duration, meaning that it doesn't mean that all Canadians are going to have their 2 doses at 4 months interval. It means that now, to be able to use up the vaccines that we're getting, which is in still limited supply, we are hoping that that first dose is given to as many people as possible. And when the rest of the bulk of the vaccines will be coming in, then at that point in time, we can shorten the interval to come back to closer to 6 weeks or so.
Thank you, Mr. Chair. Do I have a more time?
You have,
can I make
40
a point?
seconds, please.
Can I make a point of? I think it's a point of clarification. Isn't that a procedural thing you can do? Because there's something the witness said. Or am I totally wrong, Dr. Quach Tan? I think it's really important.
Mr. Chair, he can't come in here as
Doctor.
He can come as a witness here.
Just steady down, everybody. Doctor, you'll have a time slot in the 3rd round.
There's no such thing as point of clarification on the witness testimony.
It interrupts the
well, I think it's totally central to what we're talking about.
Mr. Chair, he has a speaking slot.
Doctor, we can't allow it at this time. If one of your colleagues would like to share their time with you, that would be okay. but at this point, the speaking time for all the parties is well defined.
Mr. Chair, I will share my time with Dr. Pulaski.
All right, Ms. Sidhu, you have 40 seconds left. Dr. Pulaski, you have 40 seconds.
Thank you, Ms. Sidhu, for that. So I think this is something really important, and I think probably most of the members in the committee didn't pick this up, and I would say a lot of the public may not appreciate the difference. When you, Ms. or Dr. Quach Tan, you talked about the efficacy versus, I think, the efficiency, and the numbers are very different. Can you once again just clarify that so we understand what is the difference between those two terms and what is the efficacy versus the efficiency?
Absolutely. Thank you for that question. So efficacy means the vaccine impact in a randomized control trial where you actually choose the population that you include, choosing in the sense that you have very strict inclusion and exclusion criteria. Usually your population is healthier than when you use it in real world. Effectiveness is the impact of a vaccine when it's rolled out at the population level, which means that everybody is vaccinated. You have immunosuppressed patients, people with underlying medical conditions, malnourished people who might not respond as well to a vaccine. So you always expect effectiveness to be a little bit lower than efficacy because you have a much more varied population in whom the vaccine might not work as well as when you not cherry pick, but you select very strictly the participants in a study.
Thank you, Doctor. Nous allons maintenant.
Now we'll turn to Mr. Thériault. Go ahead. You have 6 minutes. Thank you, Mr. Chair. Dr. Berthiaume, why didn't you approve AstraZeneca for people aged 65 and open? The AstraZeneca vaccination was approved based on the fact that Health Canada thought that it had enough information to recommend it for populations under the age of 65. I could tell you, though, just sufficient information, evidence, because we make decisions based on evidence. But on the other hand, we've heard about 40% efficiency or efficacy. Who listens to the information given by the advisory committee? Because we're trying to deal with a pandemic. There are two bodies that look at this, and when we're talking about the AstraZeneca vaccine, when we look at the problem, we go back and forth. Some people say, "Oh, it's been approved." If it's approved, but there's a warning about the efficacy for people age 65 and over. So when we talk about the relevance of the vaccine, are we talking about a vaccination strategy that that the decision's made because there's this resources is rare? Is this approval given without any warning? In other words, why was it approved? As I tried to explain earlier, there is a variety of data that you have to consider. For instance, for the people aged 65 years and over, there have been 0 hospitalizations and in groups that did not receive the vaccination. If you look at the efficacy of a vaccination, you look at different things. You look at prevention, the efficacy, you look at the prevention, and most of the efficacy data pertain to the efficacy. And then you have efficacy in the case of hospitalization. That's an important aspect that needs to be considered as well. In the case of AstraZeneca, there is the clinical data, but so there the efficacy in the real world as well, the real data. It has had an impact on reducing severe cases of COVID, and that is how we based our decision. So even if we have 43% efficacy for people aged 65 and plus, it does prevent serious disease. Is that an optimum? Is that an optimal decision for most people? And is this type of decision making without warning? Do you do not think it's going to create uncertainty amongst people? Today we found out that there was a problem. Who's going to make the decision? NACI is advisory. Is it going to be Health Canada? Who's going to make the decision that perhaps we're going to suspend use, as Norway has already done, Iceland as well? Why not apply the precautionary principle? 43% efficacy is not that significant because there were very few cases. But wait a minute. What are you saying? You're saying that 43% efficacy, and therefore you're saying we don't bear that in mind because it's not significant as a data. As I try to as Dr. Ashton said, the level of confidence was low. So it was in terms of statistics. 43% efficacy is not a reliable piece of data, given the number of cases. So with these recent studies that will be looked at over the next coming days, you didn't really answer my question. Who, according to the precautionary principle, are we going to withdraw the vaccination until we shed some light on this new vaccination? You're referring, is it you who makes the decision? Mr. Thériault, I'm trying to answer your question. We were referring to cases of embolisms in Europe. It was suspended in certain countries, but this wasn't done fully for AstraZeneca. Europe is doing investigations right now. I do understand. I don't have much time, Dr. Berthiaume, but I'm talking about the precautionary principle here. It's not because of problems that are happening elsewhere that that you would go ahead and say, why not? If there are things that are going on elsewhere, why not suspend the vaccination for the time? Put yourself in the shoes of someone who is 70 years old and reads the news and realize that there's no consent with respect to the consensus with respect to the vaccination. Don't you think it's going to create a lot of uncertainty? And don't you look at the confidence level of people? Isn't that part and parcel of your vaccine approval process? It's time that we shed some light on this situation. The cases that you refer to, the cases of embolisms, are being looked at. Health Canada is in direct communication with other agencies, and if there was an emerging problem, Health Canada would take the necessary action. But you can't affirm anything right now. You can't confirm anything right now. You should be able to be cautious and perhaps withdraw the vaccine temporarily. Thank you, Mr. Thériault.
Go now to Mr. Davies. Mr. Davies, please go ahead, 6 minutes.
Thank you, Mr. Chair. Dr. Quashtan, NACI on March 1st, about 10 days ago, said this about the Oxford AstraZeneca vaccine. They said NACI does not recommend the use of the AstraZeneca COVID-19 vaccine in individuals 65 years of age and older due to the insufficiency of evidence of efficacy in this age group at this time. Do you stand by this statement?
Sorry, I'm on call. They were calling me at the same time. You were saying if I still stand by the statement we issued on March 1st. Yes. So as we said, we're reviewing the data. We met yesterday.
I'm not asking if you're reviewing the data. I'm asking if you stand by that statement.
As of now, yes, because we're reviewing it at this point in time.
Thank you. Now, Ms. Elmsley, you talked about changing over time. Well, the reason we're having this meeting tonight is because there's a simultaneous contradiction in advice, because at about the same time, Health Canada's summary of the rationale for its February 26th authorization, just days before NACI said what it said, is Health Canada said this: efficacy in individuals 65 years of age and older is supported by immunogenicity data, emerging real-world evidence, and post-market experience in regions where the vaccine has been deployed, which suggests at this point in time a potential benefit, no safety concerns. How do you square that? We have NACI telling us there's insufficient evidence of efficacy, and Health Canada at the very same time is telling Canadians that efficacy is supported by data. So help me understand that contradiction. And who should Canadians believe?
What I would say to that is that data are being looked at by NACI and its experts and by Health Canada and their experts. And so from the point of view of the regulatory approach, Dr. Berthiaume can speak very well to that in the context of making decisions on the safety, efficacy, and quality of vaccines to be authorized for use in Canada. NACI is going to look at this from the perspective of the use of the vaccine, the optimal use of the vaccine in Canada.
No, that's not the case. I read a direct quote where both groups were speaking about efficacy. One was not talking about use and the other about efficacy. Both were talking about efficacy. NACI said there's not sufficient evidence. Health Canada said there is. Now I'm going to move towards what Dr. Nathalie Granvaux, professor in biochemistry and molecular medicine, told this committee this week. She said, Health Canada authorizes vaccines based on the clinical trial data, and NACI subsequently adjusts the recommendations for their use based on real-life data as it becomes available. It goes without saying that the different messages emitted by these two organizations induce a major confusion that is incomprehensible by the majority of the population. This is without taking into account the additional confusion induced by the different opinions of the provincial advisory committees. It is important to understand that inconsistent messages will likely lead to a loss of confidence in the population in the vaccination campaign, and one cannot risk losing the adhesion of the population to immunization with the safe and effective vaccines that we have. Is she wrong, Ms. Elmsley?
I would say she is not wrong. I think that it is important that we always drive to clarity and consistency in messaging. That is our objective, for sure. In this situation, as science is evolving, it is just sometimes not possible to be there at exactly the same time. And we need to accept that. Canadians need to, and I think they do understand that science is evolving very, very rapidly at a very fast pace. And experts on NACI and experts at Health Canada are very seized with looking at this on an ongoing basis and making their best recommendations for the benefit of all Canadians.
Well, let's turn to real-time evidence then. Dr. Berthiaume, Denmark, Norway, and Iceland today announced that they will temporarily suspend the use of the Oxford AstraZeneca vaccine as a precaution after, quote, reports of severe cases of blood clots in people who have been vaccinated with the COVID-19 vaccine from AstraZeneca. This follows a similar move by Austria at the start of this week, where authorities are investigating the death of one person and the illness of another after they received doses. Is Health Canada currently investigating these reports of potential adverse effects? And in your view, should Health Canada temporarily suspend use of the Oxford AstraZeneca vaccine as a precaution while these reports are investigated? And if not, why not?
Well, thank you for your question. As very well explained by Dr. Quash, the clinical trial data is very robust when you look at it. So when you look at the data that was generated for the AstraZeneca vaccine, 24,000 people were in the clinical trials, and the level of adverse events, the severe adverse events that were identified were not different between the vaccine and the people that got the control. So we have strong data to support the fact that there's no safety concern with the vaccine itself. They've been reports in Europe of thromboembolic events, and they're investigating them. What will have to be determined by the regulatory authorities is whether or not there's a causal relationship between those situations and the vaccine.
I know what happened. The issue, it's not that they're investigating, they've suspended it. I just named you 4 countries that have suspended the use of that vaccine. It's not just investigation. But I want to move to something else. Last week,
Mr. Davies, thank you.
I have to say, Mr. Chair, you gave the Liberals an extra 2 full minutes, and you also gave the Bloc an extra full minute. I was timing, and I know that's the case. I would like to get one more question in fairness.
I don't think it's correct that I gave the Liberals 2 minutes, or certainly, Mr. Sometimes it happens that answers go over the time, and I try not to cut people off. But you'll have another opportunity in the next round. That ends round one. We'll go to round two starting with Mr. Barlow. 5 minutes, please.
Thank you very much, Mr. Chair. And just to continue on with Mr. Davies' questions, do we know, either Dr. Bertium or Dr. Quash, do we have any of the same batch of the AstraZeneca vaccine that has caused the problems in Europe and Scandinavia with the blood clots? Do we have any? Do we know if we have any of the same batch of that AstraZeneca vaccine in Canada?
So yes, thank you for your question. Yes, we know the answer to that, and the answer is no, we don't have the same batches here in Canada.
The WHO and the FDA have set minimum standards of efficacy of the AstraZeneca vaccine of 50%. Do we have a similar standard that has been set by Health Canada or PHAC?
This standard has been adopted internationally.
So if we have the same standard of 50% in Canada, why are we approving the use of the AstraZeneca vaccine that has not met that minimum standard in Canada?
The AstraZeneca vaccine has demonstrated 100% efficacy in clinical trials to prevent cases of hospitalization. So there has been evidence of efficacy, but on the symptomatic cases, the data was not sufficient because the number of cases was too small, right, because the number of patients in the clinical studies was too low.
So to that question, Dr. Bertiol, it sounds like you're being creative with the numbers. That the stats that we have is AstraZeneca is 43% for efficacy. So either the answer is we're approving the use of AstraZeneca that is either 43% efficacy, or we don't have enough data. So are you so to me, it sounds like you're approving the use of a vaccine that is below the standard that is set internationally. Either it's 43% or non-existent.
So if I can comment on that, please. So the standard for the 50% is the overall efficacy of the vaccine. It's not subject to subpopulation analysis. So it's the overall efficacy of the AstraZeneca vaccine is 62%. And when the doses are spaced, there's some evidence suggests it could go up to almost 78%.
You were kind of touching on the problem, I think, that all of us here on this committee are having, and I would argue the vast majority of Canadians, where every single time we're asking who we would expect to be experts questions on this health committee, we are getting different answers, different numbers, different statistics, and it's like and I don't want to say you're manipulating numbers, but you are finding a way to ensure that AstraZeneca fits a very narrow window where the vast majority of Canadians, the confusion here, when we're hearing what's happening in Europe and Scandinavia and on this panel, you're giving answers that are very different to each one of us on this committee, whether it's myself or Mr. Davies or Mr. Theriault.
So Health Canada's information.
I haven't asked you a question.
Sorry, am I sorry?
No, it's okay. Has to either Dr. Bertium or Dr. Quash, has the Minister of Health raised the concern of the confusion and the impact that will have on vaccine hesitancy or concerns amongst Canadians? Has the minister raised the concern this confusion is causing with Health Canada or PHAC?
Well, I can tell you that the Minister of Health hasn't raised anything with us. We just realized, not being stupid, that having conflicting recommendations is going to be a problem. And that's why we're aiming to have, technical briefings and whatever to explain why there are divergences. The problem is we are an independent committee. So as much as we would like to all say the same thing, I think that aiming for uniformity would then means that if we were not in agreement, we would have to comply. So I'm not sure that aiming for harmony is necessarily what we should be doing.
Well, I would argue, Dr. Quash, in the opposite. Canadians are looking for direction. And when we have two organizations who we should trust giving us two different answers, you can understand the concern and the worry that this is causing amongst Canadians. So I have time for one last question. The AstraZeneca vaccine that we've been given has an expiration date of early April. Is there any data that shows that the closer that vaccine gets to its expiration date, the efficacy or effectiveness of that vaccine deteriorates? Is there any data that shows that it is just as effective on the day of expiration date as it is a week before that expiration date?
So the answer is that a pharmaceutical product or a vaccine is as good as the first date as the last date of the before the expiry. So yes, from a quality perspective, it's as good as if it was further from the expiry date.
Thank you, Mr. Barlow. We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 5 minutes.
Thank you, Mr. Chair. And I'd like to take a moment to acknowledge the 1-year anniversary since COVID-19 was declared a pandemic and the lives across Canada that have changed, and some of them forever. Today, my respect goes out to all who have lost loved ones and friends, and our healthcare heroes that have been at the front line of this fight since the very beginning, and our scientific community, including the ones that are here with us today. So I want to thank you all for joining us. I'll start with a question for Dr. New. I believe some Canadians may not be aware of the reason why COVID-19 vaccines use a 2-dose schedule to reach the very high levels of immunity. Can you walk us through how each of us will gain immunity to COVID-19 through vaccination? And let's start with getting the first dose and going through to the second. Dr. New?
Well, thank you very much for the question. I would also defer to Dr. Quashtan for further comments, because certainly I would say that Nasi and Dr. Quashtan and the other members went through the evidence to look at exactly what the real world data shows in comparison to the clinical trial data that was obviously used by Health Canada in terms of the approval of the vaccine. And based on the very good evidence that was presented, for example, even Canadian evidence, what happened in British Columbia and in Quebec in terms of a high level of protection, even after 1 dose, to the residents in long-term care facilities. And the fact that based on the principles of vaccinology and immunology, we know that immunity just doesn't just drop right off after a few months. And certainly there's been no evidence from other experiences in other countries that has been the case. That's why, and certainly I would defer to Dr. Quashtan, they came out with the recommendation that the interval could be extended up to 4 months. But as Dr. Quashtan has said, I think that it doesn't mean that every Canadian who will get the first dose will have to wait exactly 4 months. It all depends on terms of the shifting of supply, because obviously we're anticipating getting many more millions of doses into the second quarter and beyond. But I think overall, from a population health perspective, the thinking is certainly the provinces and territories, the chief medical officers of health, having heard the presentation by Nasi, this was, I think, a week or so ago, are of a general consensus, yes, that it makes sense to immunize more Canadians rapidly with that first dose, given that high level of protection, to have that overall high level of what we call it population protection. And then certainly as the doses come in a more sort of a greater quantity, that they would be able to give that second dose. So that, I think, is the overall end result in terms of how the provinces and territories are taking the Nasi advice, and obviously within their own context, operationalizing it to the maximum benefit of their populations. Thank you.
Thank you. I'd like to share my time with Dr. Pawlowski, but I just want to clarify one point. Dr. New, the doses are administered after the advice of professional medical doctors and not administered by rote. Is that correct?
Well, at the end of the day, yes, giving a vaccination is a sort of a clinical medical decision. At the end of the day, it really is a medical act between let's say a health professional and obviously the patient. And I think, you know, in the normal ideal setting is that there's always informed consent, that the patient is obviously you know, informed about the risk and benefits. That's sort of an individual interaction between a physician or healthcare provider and the patient. What I think you're also referring to is that at a population level, from a programmatic perspective, certainly as the vaccine programs are rolled out in each of the provinces and territories, that overall sort of a stance and operationalization has taken that population perspective into account.
Thank you. I'll turn it over to Dr. Pawlowski.
Dr. Pawlowski, you have 45 seconds.
I'd like to ask a question about the association with the vaccine AstraZeneca with DVTs, PEs, just because some of the very many people who've got the vaccine developed a PE or DVT obviously doesn't mean a lot. In a place like Thunder Bay Regional Hospital, population 100,000, we may see 5 to 10 DVTs or PEs every given day. So how many people actually got a DVT and PE, and how does this compare with the overall incidence of those things in the general population? Because from what I hear, it doesn't sound all that impressive an association.
Sorry, is this a question?
Quick answer, please.
Okay, so yes, that's the point I was trying to make before, is that those events occur naturally in the population, and to make a link between the vaccine and the event, you have to determine that the rates of event is higher than the natural occurrence in the population, which has not been made at this point in time.
Thank you. Thank you, Dr. Pawlowski. We go now to Mr. McGuire. Mr. McGuire, please go ahead, 5 minutes.
Yeah, thank you, Mr. Chair. I may share some of my time with some of my colleagues who have questions as well. I know, Ms. Cook, you indicated that you were looking at, I mean, you are an independent committee, there's no doubt about that, but your decisions are public. You are experts in these fields and the public knows that. And so do you not feel that there is an expectation amongst the public to basically be baited on every word that you're saying, because the contradictions here have certainly left skepticism amongst the Canadian public as to what they should do in regards to vaccines. We've talked about vaccine hesitancy. Can you just elaborate on that?
Yes, absolutely. Thank you for the question. I think we have to realize that Health Canada authorizes a vaccine or a medication, and it's not the first time that the clinical guidelines will differ from what has been authorized. In this particular case, Health Canada deemed that the vaccine was safe enough and efficacious enough to be used in all age groups, which is their decision. What we had in terms of data did not make us comfortable enough at that point in time to allow for the use of AstraZeneca in the 65 plus. I realize that since then, real world evidence has emerged. And as I said, we met yesterday to review that data. And it's possible that at points in time that we will differ in opinion. But I would ask the members of this committee if it would be preferable, you think, that we would have aired with Health Canada, even though in our opinion, we weren't ready to make that recommendation. I think that we may make recommendation based on multiple issues, including looking at other vaccines that are available. As I said, we had 2 mRNA vaccines, which were highly efficacious in the 65 plus. And our mathematical modeling showed us that what we had proposed was actually a recommendation that was completely sane, and that's what the committee was comfortable with.
Yeah, I know the other side here too is we were talking earlier about the time frame that a few days can make a difference in the change of advice. Well,
yes,
this was 2 days, and such conflicting views within that 2-day period. I know that science has been extrapolating right through this whole process for a year now, but for the public to absorb the fact that the change took place before the vaccines even got here with AstraZeneca. Can you tell us why?
You know, had we known that the Public Health England was going to publish their real-world evidence showing such a high effectiveness in preventing hospitalization the next day, we would have waited an extra day. But it's easy when you look back.
Would that have changed your mind?
As I said, we have looked at that, and the recommendations will be updated. But you don't know what's coming in front of you. It's impossible. moving forward. So at one point in time, you have to say, these are the data we had, and we had said to the Public Health Agency of Canada that we would aim to get a recommendation out for AstraZeneca within days of Health Canada's approval, because of the fact that vaccines were going to be used in Canada, and therefore provinces and territories needed to know how to use them.
But you would have had you would have had information before you that indicated that some of these products hadn't been used in certain sectors of society, certain age groups, certain races, other areas, people with other health concerns. And so why would the recommendation come out for not being used on anyone over 65 if you knew that there were other areas that hadn't had trials?
Not sure I'm following your question.
Well, there wasn't efficacy done in some of the other, younger age groups, or certainly they're saying you shouldn't use it in anybody over 65. But
we had data in the 18 to 64, and with a confidence interval that did not include 0. So I'm not sure what you're referring to.
And so you didn't have it, but then you know that there was conflicting views within a few days of the decisions that you were making.
There were conflicting, but the fact that Health Canada and our recommendation do not align are not conflicting views to my sense. Health Canada is looking at data with a different paradigm. We are looking at the data, knowing what else we have in our portfolio. Health Canada is not ranking one product versus the other. We are.
Mm-hmm. Thank you, Mr. McGuire. We go now to Mr. Fisher. Mr. Fisher, please go ahead, 5 minutes.
Thank you very much, Mr. Chair. And at the start of every time I get a chance to speak at committee, I always thank the witnesses. But I got to tell you, I am so appreciative that we have experts and scientists like the people on this panel and the people at Health Canada and the people at NACI that are making these decisions and these recommendations for provinces and territories, and not politicians. My gosh, what a state we'd be in. Thank you so very much for all that you are doing. We talk about NACI, and we heard that they're an independent expert advice providers for over 50 years and appreciated by provinces and territories for 50 years. I mean, this is absolutely, so I guess my question would be probably to Kim. I'm going to go to Dr. Quashtan. When it comes to the health and safety of Canadians, we know that we need to rely, as I said, on experts in science. It's imperative that medical decisions are made by health professionals, experts, and as I said, not by politicians. Canadians need to know that the vaccines that they're taking are safe, and that the recommendations made for their use is based on what is best for them and what is best for Canadians across the country. So Dr. Quashtan, can you talk just a little bit more about the role of the National Advisory Committee on Immunization? Who does NACI create their recommendations for, and what factors are you considering when making those recommendations?
Yes, thank you for your question. So basically, NACI creates their recommendations for provinces and territories, so that each province and territory can then take up the recommendation and apply it to their own epidemiology, jurisdiction, logistics, concerns, etc. Once our recommendations are out, it is then taken up, mashed up, and put into the Canadian Immunization Guide, which is used by healthcare providers. The problem with the pandemic is that everything changes so quickly that the CIG does not have a piece about COVID vaccine, so that healthcare professionals are looking into the statements to try and understand the backgrounds to our recommendation. So that piece is happening, but it's a little bit delayed. And so we've decided that the statement would be at the same time used by healthcare professionals and provinces and territories. NACI does not speak directly to Canadians usually. We are there to support the public health measures. And so having people trying to go through it and understand it might be more complicated. And we realize that the language we use is not a layman language. It is what public health understands and what healthcare providers understand. And even at that level, some healthcare providers called us and said, we're not sure we understand your differences between strong NACI recommendation and discretionary. because this was based for provinces and territories. The elements we look at to make a recommendation are burden of illness, vaccines characteristics, so including safety, immunogenicity, efficacy, and effectiveness, but also, as Kim said, ethics, equity, acceptability, feasibility, mathematical modeling, and economics. When it comes to that, at this point in time, economics hasn't been incorporated in NACI vaccine decisions because regardless of how much it costs, we are going to use those vaccines. And so when we look at all those elements, it is possible that a little bit less efficacy will be trumped by the ability to deliver more vaccines to more Canadians, because in our mathematical model, when you compare various possibilities and various scenarios, that seems to be the most optimal. Are we always right? I can't say that we're 100% right. I mean, things are evolving. You make recommendations based on the best of your knowledge. And we really work at this from a generous and, de bonne foi. There's nothing here that we're trying to conceal. And so it just happens that this time around, Health Canada and us did not say the same thing. But as I said, it's not the first time it happens. It's just the first time people notice.
Thank you. Do I have any time, Mr. Chair?
30 seconds.
Okay, so to some extent, I think Dr. Quashtan, actually Kim, the opposition is helping to sow some of this confusion. They continuously talk about how Health Canada ignored the advice of NACI. Kim, maybe you could tell us how NACI and Health Canada have totally different mandates.
Yes, and of course I'll turn to Dr. Berthiaume in terms of the regulatory mandate. But as we know, Health Canada carries the mandate to regulate vaccines, and therefore it looks at clinical trial data from the manufacturer to understand and assess quality, efficacy, and safety of vaccines. NACI, of course, is using similar data and looking also at real world data as it becomes available. And the mandate of NACI is very much to use the expertise on that committee, which is very multidisciplinary, to provide advice to provinces and territories on the how of using authorized vaccines in Canada. So
and the provinces choose to take that advice or not. They decide whether they're going to take that advice from NACI.
That's absolutely correct.
Mr. Fisher, you're done. Thank you.
Thank you.
Nous allons maintenant à Monsieur Thériault.
Mr. Thériault, please go ahead. You have 2.5 minutes. Thank you, Mr. Chair. There's a problem with the translation, but at any rate, there was no translation provided. But that being said, I'm glad that NACI is not is taking this very seriously, and they don't necessarily go with when they have doubts, they say so. It's the Public Health Agency of Canada has to ensure that there is a uniform message, and we need to have confidence in the public. We now have a vaccine where we don't have a choice, really. We're told you take what's available. Don't you feel, Ms. Hemsley, aren't you uncomfortable with the fact that there are 300,000 AstraZeneca doses that are arriving? And in addition, there have been some adverse effects. Some countries have decided to suspend the vaccine until further studies made. Are you uncomfortable with that situation? Don't you getting 3,000 doses and that within a month, does that not cause you any concern?
Of vaccine safety. That is, of course, the highest priority for the Public Health Agency of Canada and our work with our colleagues at Health Canada.
Excusez-moi, il n'y a pas de traduction.
So from that perspective, the safety system in Canada is very strong. We have a system that works with manufacturers, with provinces and territories.
Pardon me, could you make sure your mic is in the right place? And yes, absolutely, Mr. Theriault. If you have a problem, raise a point of order immediately so we can deal with it. Say a few words, Ms. Helmsley, and we'll see if the translation is happening.
Is the translation happening now?
Monsieur Theriault, can I have a thumbs up or not?
Is there a translation?
Ça se fait présentement, merci.
Yes, I'm getting translation now.
Go ahead, Mr. Theriault. I will resume your time at this point.
Thank you. I'll just, if you don't mind, conclude quickly by saying that the safety system in Canada, very strong. It is watching very carefully for any safety signals, investigating any side effects that occur after administration of COVID-19 vaccines. Dr. Bertillon.
Non, c'est pas ma question.
That wasn't exactly my question. Perhaps I wasn't clear enough. But according to the news, we're getting 300,000 doses that are going to become obsolete on April 22nd. And NACI doesn't, Health Canada doesn't take into consideration what NACI is saying. What about the confidence the public can have in the vaccination? Is that the time that I have left? Do I get any additional time because of what happened? Yes, you do. Can I get an answer to the question?
We'll get an answer to the question and then move on to Mr. Davies. Please answer the question. Thank you.
Thank you for the question. And if I understand then correctly, you were talking about the doses of vaccine that are coming into Canada and their use within the time frame, if I understand correctly. And as Dr. Bertillon pointed out, those doses are usable from the point of them coming until the expiry date. So we're not concerned about a tailing off of effectiveness. But perhaps I have misinterpreted your question.
Merci, Monsieur Theriault. We'll go now to Mr. Davies. Mr. Davies, please go ahead. 2.5 minutes, please.
Thank you, Ms. Helmsley. Last week, it was confirmed that 300,000 of the 500,000 AstraZeneca doses that Canada received from the Serum Institute of India will expire in just 1 month's time. Did another jurisdiction or purchaser reject those doses?
I do not have any information on that question. I will certainly be happy to get back to you with an answer, but I'm not aware of that.
Thank you. Dr. Quastran, in light of NACI's recommendation against use in adults 65 and older, are you confident that those doses will be administered before they expire?
I hope so, but the rollouts are of provincial jurisdiction, so I don't have any say on that matter.
Okay. I want to turn to the issue of extending second doses to 4 months. Cole Pinot, the president of Pfizer, said this week to this committee. All the research to date on our vaccine has been done with 2 doses that have a schedule of 21 days. The recommendation that's been put in place by NACI, as highlighted earlier in Canada, is the only one in the world which is recommending an extended dose delivery. The data that we've seen from a real world evidence perspective that has been used to make arguments to extend the dose schedule has been done on much younger populations. The fact is we don't have any data after 2 months to know what the impact of 1 dose will be. Is extending the dose interval to 4 months a responsible one for older populations in light of what Mr. Pinot told this committee?
Yes, so as I said, you're right. We have data up to 2 months on including long-term care facility residents in whom the vaccine effectiveness is above 80% and in which we don't see a decline of vaccine effectiveness over time up to 2 months. What the modeling has shown us is that even if we were to include a 5% decline of that vaccine effectiveness over time, the benefit in terms of decrease in hospitalization and mortality at the Canadian level was still beneficial.
Well, that's your speculation based on modeling. It's not based on data.
But you know what? Because we're in a pandemic, at times we have to make decisions
fair enough. Yeah,
difficult.
fair enough. I'm just trying to figure out what it is we're basing it on. My last question is Dr. Mona Niemer said the following with respect to that. She says, this amounts right now to basically a population level experiment. I think it's really important that we stick with the data and with the great science that gives us these fantastic vaccines and not tinker with it.
Is this a population level experiment?
You know that during the pandemic, everything is more or less a population level experiment. When we decide to do a lockdown and when we decide to do other things, we don't necessarily have the data. We have to make decisions based on incomplete data. And that's why you have experts who will generalize from what they know from other situations to try and make the best decision. I agree that if we had that data, it would be perfect. But waiting to have that data just makes it impossible to reopen the economy, try and vaccinate the population, get children back to school. And so at one point in time, not deciding or deciding to stick with the on-label recommendation is often much easier, but it doesn't mean that in the end, it will end up giving us the best outcome for our population. And so trust me, if I was able to just stick to label, I would. My life would be so much easier today. But I don't think, and the committee didn't think that that was the best thing to do for the Canadian population. And so we recommended to try and use the first doses in as many people as possible and give the second dose when they would come. As we said, the 4 months is the maximum interval. It doesn't mean that you stick to 4 months. It just means that you can go up to 4 months to try and curtail the pandemic as quickly as possible and try and combat variants that are showing up a little bit across Canada.
Thank you, Mr. Davies. That was actually
Thank you.
just about an extra 2 minutes. We'll start round 3 now with Ms. Rempel-Garner. Ms. Rempel-Garner, please go ahead, 5 minutes.
Thank you, Chair. Just continuing on with Mr. Davies' comments. Ms. Quashtan, did you have data that you were able to table with committee showing that any potential risks associated with the 4-month interval outweighed the benefits that you just stated, or vice versa? My apologies.
So there is a bulletin that was published last week from NASTI with the pros and cons of that recommendation. We will be having more data in that statement when the provinces have published their data. At this point in time, they were provided to us, but under confidentiality agreement, and we're waiting for those to be public to update that statement.
Would you have made that recommendation if there had been more supply of the Pfizer vaccine?
Of course not.
On January the 7th in Montreal, the Montreal Gazette, you said that the Pfizer and Moderna vaccines use a new technology. It can't be taken for granted that what has worked in the past will also work now. My gut feeling is that up to 6 weeks, I won't have any problems. After that, I can say up to 12 weeks, there are still problems. Still no problems? I'm not sure. Is the 4-month recommendation a gut feeling?
So it's based on the data that we have from the UK, from BC, and from Quebec, where up to 8 weeks, we see that actually the effectiveness is quite good. It's, as I said, we don't have data for up to 4 months in terms of effectiveness, but we have modeling data and we have expertise in immunology. And, it's really a decision that was very hard to take. But
you wouldn't be making that decision had there been supply of the mRNA vaccine.
If we had enough vaccines to vaccinate all Canadians quickly, and at least those most at risk with 2 doses of vaccines, we would not have needed to extend the interval. That's for sure.
That's interesting. You started talking about the Pfizer vaccine being used, the 4-month interval. You characterized it as an off-label usage. Would that be a correct characterization?
Absolutely.
Do you know if I'll go to Health Canada, are there any contract implications for using the Pfizer vaccine for an off-label usage or recommending in this manner?
I'm not aware of any contract details. Those were dealt with Public Service and Procurement Canada.
And on that, I'd like to pause my time for a minute, Chair. Point of order. We did ask that Dr. Roman Sumsky, the Senior Vice President of the Vaccine Acquisition Branch, appear before the committee as part of this motion. Could you tell me why he's not here tonight?
All of the witnesses requested were invited, but they weren't all able to attend. I also will note that the bells are going. So we need unanimous consent to proceed. I suggest we might be able to squeeze in another, if the rest of this round, but I'll ask the committee if they wish to do that. Is there any will to try to squeeze in the rest of this round before we suspend or adjourn for the vote?
Sure.
I'm seeing general consent, so we'll carry on. And if it looks like we're running too close to the wire, we'll pull a plug then. So thank you all. We'll carry on. Ms. Rempel-Garner, please.
Thank you, Chair. Dr. Quashtan, do you know how many doses of the Pfizer vaccines we would have needed in Q1 in order to avoid the recommendations that you made?
You would have to ask the Public Health Agency of Canada how many, and they have that data, it's just that I don't know them by heart, how many people fell into the highest risk categories.
Ms. Elmsley, would you table that with committee, preferably in a quicker pace than, or without having me to make me put a motion to compel it here, like let's say in the next week?
Yes, we will take that back to the department. Thank you.
Okay, and Ms. Elmsley, I will note that I might have to put forward motions to compel information from your committee that has that you've said you would provide that have not been provided yet, and I find that unacceptable. Dr. Berthelm, have you had any interaction with the with Pfizer or Health Canada with regard to the decision on the dosing interval between from going from 3 weeks to 4 months? Have they advised you in any way on that?
I'm sorry, I'm not sure I understand the question. So the discussion between Health Canada and Pfizer were for the approval, and they continue about ongoing data safety issues, but the way the doses are administered in the provinces are not a matter that
Thank you.
is
and my last question with the time that I have left. Dr. Quashtan, did you consider, or did NACI consider the possibility of the development of vaccine-resistant variants, as a paper in the Lancet recently discussed in your decision to recommend increasing the dosing interval to 4 months of the Pfizer vaccine?
We did, and the immunologists we consulted said that this was a theoretical risk, and they wouldn't see why extending the interval would increase the risk of having variants show up. The most important thing.
Can you publish that or table that data with this committee in the next week?
It was a discussion, but I can try and get you something in writing.
Thank you. Thanks, Chair.
So thank you, Ms. Rempel-Garner. We'll go now to Mr. Kilroy. Mr. Kilroy, please go ahead, 5 minutes.
Thank you, Chair. And before I get into my questions, I just want to thank all the witnesses as well for the work you're doing on behalf of Canadians.
2 and I got none.
Okay. Marcus, I think your mic is on.
Yeah,
but I'll continue. I do want to thank you for answering all the questions tonight. It's, in my opinion, it's easy to criticize distribution plans and recommendations and decisions, and in some cases incite fear in people when it comes to the vaccines. But I have full confidence in you folks, and I know that you have the best interest of all Canadians in mind. And I'm really filled with gratitude for the work you're doing. And in my opinion, you're not just Canadian leaders. I truly believe you're world leaders. So I'm going to start off with Dr. Quashtan. Hopefully I'm pronouncing your name right, Doctor. And I guess it's a practical scenario, and it's kind of how we roll here in Cape Breton-Canso. But here in Nova Scotia, we've begun vaccinating seniors over the age of 80. My mom, she actually received her letter last week. We are all very pleased by that. And I noticed when booking your vaccine appointment, there is now up to 105 days waiting period between the administration of the first dose and the second dose, rather than the 2 to 3 weeks between the doses. And I think you've highlighted this, but this is a chance for you to do a deeper dive. I'm wondering if you can explain to the committee and those following at home, just as important, those following at home, why NACI is recommending that COVID-19 vaccine intervals between the first and second dose could be extended up to 105 days. And also, can you tell us kind of maybe a little deeper synopsis of what changed since the original recommendations?
So I'll start by the last part of your question. What changed since the original recommendation are the data that came out of the UK, Quebec, and BC, showing that at 8 weeks, we still had higher than 80% effectiveness, even in the long-term care facility residents, which to us was a sign that these vaccines are actually quite good. And as I said, given the mathematical modeling, what we did was decrease that vaccine effectiveness over time, which, a more or less steeper curve to that decline. But regardless of the decline, giving one dose of vaccine to as many Canadians as possible was the scenario that actually decreased the most the number of hospitalizations and death, mainly when you give it now, because what's important is now. Maybe Nova Scotia, you guys are great, you don't have that much transmission, but in other provinces, it's rampant. And so what we want is to decrease transmission as quickly as possible, because then you decrease the risk of having variants come up, because a variant happens when the virus replicates and makes a mistake, and that mistake is actually good for it. And so the least it replicates, because the least it transmits, then you decrease the risk of those variants occurring. And so based on those data, we've decided to extend the interval really to allow for that first dose to be given to as many people as possible. I think what is very important in all this is that we have surveillance systems of effectiveness, so that you have real-time data of what's happening in Quebec, BC, in Alberta, and probably in Nova Scotia as well. People are able to say, we're now at 9 weeks, the vaccine effectiveness is X, we're still good to go. We're now at 10 weeks, the vaccine effectiveness is Y, we're still good to go. When we see that it decreases anywhere, it's then easy to say, okay, we're rolling back the vaccines and we're starting to give that second dose now. All it means is the vaccines are there. Instead of decreasing in the less than 60 in people with underlying medical conditions between 18 and 59, you bring back those vaccines and you say, those that were first vaccinated, the 70 and over, we're now giving it to them. But we have that ability to follow a vaccine effectiveness in time. And it is because of that that we're able to say, yes, we don't have all the data. I would be lying to you if I said we were, but we have the ability to change our recommendations quickly, and the provinces are doing that very well.
Thank you, Doctor. How much time do I have left, Chair? You're there.
You have 45 seconds. You have 40 seconds.
40 seconds. I'll try to get this in. I'm sure many of you here today are familiar with the famous French scientist and vaccine pioneer, Louis Pasteur. He once said, do not let yourself be tainted with barren skepticism. So I think that quote is relevant today. So Dr. Nadeau, are you concerned that questioning the safety of the delay of the second dose, despite clear science and the evidence that's available, feeds into the vaccine hesitancy? And basically, how can we reassure Canadians that all vaccines approved for use in Canada are safe and are effective?
Thank you very much for the question about the vaccine hesitancy. Obviously, I think it's a complex issue, and there's many facets to it. I think in terms of overall improving vaccine, I would say confidence in Canadians, there's multiple facets. So first of all, the fact that we have one of the I think most respected and most rigorous regulatory systems in the world with our colleagues at Health Canada, I think Canadians have assurance that any vaccine that's approved in Canada is both safe and effective. And so I think that's the first step. Certainly mass, campaigns and the press conferences that many people, I guess myself and Dr. Tam are involved with in terms of reinforcing key messages to Canadians, but the importance of vaccination and how it benefits them in terms of protecting them is also important. We also recognize, and I think this is a key point that maybe hasn't been raised, Canadians in terms of getting information to improve their comfort level with vaccines. It's not because of myself personally. I think it's because they have trust in their healthcare provider, their personal healthcare provider. So I think one of the important things that we're also doing, we've done it through various things like webinars and so on, is give the tools so that the frontline healthcare professionals and providers feel empowered and are able to give credible information so that their patients can make an informed decision regarding getting vaccinated. So I think that's a very key step. Another part also is that we recognize that there might be differing levels of maybe more reticence or vaccine hesitancy in certain, let's say, racialized communities and so on. Therefore, it's also very important to engage with community leaders in those communities. And we've seen them do that. For example, in various Indigenous communities, the leaders have come forward. they've gotten vaccinated and they've actually put it on social media and so on and say, look at this, I got my vaccine, I'm protected, my family's protected, it's good for me, it's good for everyone. So those are the kind of things we're doing. And I would say at the end of the day also, I think there is a bit of a responsibility on every Canadian. You know, the fact is that the internet's a powerful tool, and there's a lot of misinformation and disinformation and so on and so forth. And so the responsible use of the internet in terms of not, say, using clickbait and, you know, making a sort of misinformation go viral, I think is also very important. And
Dr.
finally, I
Nguyen,
would say that,
Dr. Nguyen, I'm going to have
there's
to cut
three
you off there.
segments. Okay, fine.
Thank you.
Thank you very much.
So we'll go now to back to Ms. Rempel-Garner, 5 minutes.
Thank you, Chair. Dr. Quashtan, why was 4 months selected in the dosing interval for Pfizer? Why not 3 or why not 5?
Yeah.
Why 4?
Excellent question. So what the modeling had showed us is that the ideal interval would be 6 months if we wanted to have the most gain in terms of decrease in hospitalization and death for Canadians. However, when we looked at 6 months and the supplies that we were going to have, it was said to us that we would never need to go beyond 4 months because we would have enough doses to go there. So
4 months was chosen simply based on a vaccine delivery schedule.
Vaccine delivery and mathematical modeling.
Okay, so there was no actual scientific. This was purely based on a pure procurement schedule, like desperation and a pure procurement schedule.
Well, there's a basis of science, but you're right that, you know, why 4, not 4.5 or 5 was based on procurement.
Wow, that's I'm I'm kind of shocked. Do you think that Canadians might be concerned that you're making decisions based on procurement schedules rather than solid clinical data?
Well, the thing is, we looked at a 6-month interval, but didn't think that we would need to go up to 6 months. I think that, and you can look in the literature, you have very renowned vaccinologists such as Stanley Plotkin in the US, who is recommending also to delay the second dose for as long as needed to give that first dose to as many people as
possible. But the Americans
possible.
are going to be all vaccinated by May the 1st, so it's kind of
because they have, I know, but
they have supply, right?
They have supply.
We don't. So we're at the heart of this here. We are, to use the chief science officer's words, conducting a population-based experiment on a non-data driven dosing interval because we failed on procurement. Is that a correct characterization?
I can't tell you how procurement works. It's not my.
But we don't have the supply, and so we've been forced into this corner because we don't have the supply.
I think that given scarcity of vaccines, you have to make the best decision given what you have.
I'm sorry, it just blows my mind, and I know it's not your fault. I know, no. I get the situation you're in, and it must be hard.
I can't say it's easy. No.
Yeah, no, I understand. So on that, I think you and I share something because I get calls in my office for people going, what should I do? Should I take the AstraZeneca vaccine? Should my mom take the AstraZeneca vaccine? Obviously, I can't say one way or the other. I have to rely on advice. But I've got you guys saying one thing, Ms. Elmsley saying everything's changing every day. And I feel like what that does is this lack of a protocol, this lack of supply is leading to confusion in the Canadian public. And it's really hard. So I'll go to perhaps Dr. New. Has the minister given you any direction to develop a better communication protocol, given the debacle on the conflicting advice and balkanization of provincial guidelines on dosing and availability?
Okay, thank you very much for the question. If I understand, no, the minister has not given me any personal direction in terms of communication. I think it's fairly clear.
Do you think it's necessary though? Do you think this kind of seems like a bit of a cluster in the public? Do you think that perhaps a better communications protocol is needed at this point?
I think in the general area of risk communications, we could always do better. I think even myself
what would
personally.
You do better? Like, what would you say to that person who is really confused right now and is listening to this testimony saying we're going way off label on dosing interval because we don't have adequate supply?
I would say that go to your trusted healthcare professional, because
who is that here? Is it you? Is it
no,
Nancy?
it's the family. It's the family doctor, the person that actually would administer the vaccine, because
so now doctors.
The decision would be obviously with the programs in the provinces and territories that made the decision in terms at a population level.
You kind of get it. Kind of feels like it's
then
like
it comes down to the individual healthcare professionals and
so now it's
the
the doctors. So it's
Point
like
of order,
not
Mr. Chair. Point of order. If the member doesn't want to hear the answers, maybe she shouldn't ask the question.
No, I'm just very frustrated, Chair, and I think a lot of Canadians are as well. It feels like there's a lot of, and I get everybody's got a heavy job, but there's a lot of finger pointing here when I think some responsibility needs to be taken, and perhaps by the minister. Thank you.
Okay, thank you, Ms. Rampel-Garner. So it's coming clear to me that we're not going to be able to finish this round before the votes. So on that basis, I suggest that we suspend and resume as soon as we can all get back here after the vote. So and we will resume with Dr. Pawlowski, followed by Mr. Theriault and Mr. Davies. So with that, members, we are suspended for.
Mr. Chair, can I just have a quick point of order? I mean, I can vote virtually. I don't know if my colleagues can, but if we all can just vote virtually, why can't we just carry on the meeting? And I mean, it'll take me 30 seconds to vote on my phone virtually. Does anybody on committee have to be present in the chamber to vote, or can we all vote virtually?
Well, I think that if we want to do that, that's going to require a unanimous consent to do that. We can all vote virtually. I think all of us are in our respective, non-chamber locations. I know that we're still kind of, I'm still not 100% confident with that all the technology has been worked out. So I'm much more comfortable being logged in to the Zoom session. So, but I'll ask the committee if there's anyone who if we have unanimous consent to carry on right through and vote virtually, I'll the suspension will probably only be like 20 minutes, 25 minutes. So.
Well, I would say out of respect for the witnesses' time as well. I mean, it seems like we only have about 10 minutes of time left anyway, don't we? So, anyway.
Yeah. I don't know exactly. I have to look at my virtual thing here.
And 48.
We have 10 minutes, 48. So we don't have time for Dr. Pawlowski's statement or question, as well as yours and Luke's. So I think we do need to.
No, Mr. Chair. Sorry, what I meant was we only have about 10 minutes left of questioning. So.
Well, that's what I mean. I don't think we've got. We could try and shoehorn that in, I suppose. Is there will of the committee to carry on a little bit further?
I don't support that, Mr. Chair. Unfortunately, this is a very critical vote for the House, and if there are any glitches in the system, I think that I would want my voice to be heard, and therefore I would want to sign in and be present.
Great, thank you, Mr. Van Bynen. So we will suspend and resume as soon as we can all get back here after the vote. So it shouldn't be too long, and apologies to the witnesses. We are suspended. thank the witnesses for hanging in there with us all during the vote. It's one of the costs of doing business in this place. And
just a second, Mr. Chair. The petition's not ready. Just a second.
Okay. Well, it's.
Just a second.
Okay. I was saying nice things too. Good with translation?
Not yet, Mr. Chair. Just.
Mr. Clerk. So as said, we are resuming a meeting number 24 of the Standing Committee on Health as we continue our study into the consequences of the COVID-19 pandemic. And I certainly want to thank the witnesses for hanging in there while we had to suspend for that vote. It is certainly one of the costs of doing business. And I certainly, we are certainly very much aware of the kind of time and effort you guys put in on a daily basis. And so it's really appreciated that you're able to hang in here with us. So with that, we will resume our third round of questions with Dr. Pawlowski. Dr. Pawlowski, please go ahead. You have 5 minutes.
Okay, so I think Ms. Rumpel-Gardner asked the key question, which is Canadians want to know, is this a good vaccine? Should I recommend for my parents if they have the opportunity to get this vaccine? My brother's got a lot of underlying medical problems. I think the answer is yes to those. But unfortunately, in this meeting, it's about as clear as mud as far as I'm concerned, because there's so many different numbers out there. And I think part of the confusion is the difference between efficiency and effectiveness. So I'm going to direct this to Dr. Quash Tan, because I think she knows the numbers pretty well. So my understanding of the efficiency, and that came from the phase 3 randomized control trial where you had either the vaccine, the AstraZeneca vaccine versus placebo. Overall, the efficacy was 62%, but it was something like 40-something% in people over 65. However, my understanding was, I think in North America, the efficacy, so it showed 72% efficiency, and with half the first dose, 90% efficiency. Okay, that's on this randomized control trial where you pre-select the people. Now, the actual real world experience, the effectiveness, now that has actually shown AstraZeneca looking better. And there was from Lancet, Hong in Poland, study, I think 17,000 people. This was one where they looked at giving the booster 4 months afterwards. They found an 81% effectiveness, including in the elderly. The other numbers I saw when you use a 4-month interval with spacing, 76 to 82%. So certainly a lot better numbers than the 62, 40 something. And then also, if you look at the efficiency from the, or efficacy or efficiency from the actual trial with AstraZeneca in preventing deaths, it was 100% effective in preventing deaths. In hospitalizations, the Scottish study showed 94%. But you're not going by those numbers. So is that about right? So people who got the vaccine in the actual study by AstraZeneca, nobody died. And when you're giving it 4 months apart, it was actually about 80% effective in preventing clinical illness. Is that right? And as for the hospitalization, what's the hospitalization?
Right. So you're right that it's very complicated because there's so many numbers, but basically the 60% is the overall efficacy estimate. If you look at people who got it with a longer interval, so 12 weeks and over, you're right that then it goes up to over 80%. In the effectiveness in real world in terms of preventing hospitalization and death is above 80% even for elderly population. What I was saying is that those data came out after the NACI recommendation was released on March 1st, and therefore these data are being included in the updated statement that will be published within the next few days.
Okay, so the updated data, is that from the Lancet study, is that, or is there some other data supporting the use in people over 65?
So there's 2 Public Health England publications. I can't remember exactly what journals they were in, but they are those 2 studies that are being added to the bulk of the corpus of the evidence. And so they are all real world effectiveness. We do not have new efficacy data. These will come out when the US trial will be looked at, which should come somewhere in April.
So, and to reiterate, the effectiveness is actually the more impressive number, the better number. We would actually have thought that the other way, it would be the other way around, that the efficiency would be higher. So I think when you actually look at the numbers for AstraZeneca, really not too bad. The other thing I wanted to ask you about was the Scottish study. Now, I think that's based on the NIH automatically has data collection. And my understanding was in that there were over 400,000 people, many of them in their 80s, who got AstraZeneca, and they were reporting a 94% reduction in hospitalization. Now, I realize you said if you looked at the data, they were reporting a pretty significant reduction in hospitalization in the first few weeks, which doesn't make much sense immunologically. However, when you look at the total numbers, 400,000 plus, that's a pretty well-powered study.
I wasn't talking about power. The problem is that there is a bias in the study because people who were vaccinated are very different from those who weren't. And not being able to explain this 70-something% effectiveness in the first 2 weeks of following vaccination in terms of decrease in hospitalization just makes you wonder, what's the problem with that study? So we have better studies. It's just that based on just that study, we didn't feel comfortable changing our recommendation at that point in time.
Thank you, Dr. Pawlowski.
We'll now turn to Mr. Theriault. Please go ahead. You have 2.5 minutes. I have a little question, and then I have more of a methodological question as well. Dr. Berthiaume, in order to ensure that people are confident in the process, wouldn't it be better to be proactive, given that there's no linkage between being proactive and the fact that 3,000 AstraZeneca are going to expire on April 2nd? Do you not feel that we'd be better off suspending the vaccination process? It's a question of 2 or 3 days, perhaps. How many days to find out whether we have a good understanding of what's happening in Denmark and Iceland? Thank you very much. Health Canada received notification that there was no problem with the Canadian doses. What's occurring in Europe right now is that they're investigating, but there are various notices that have been issued. The probability is that these events were tied to don't have anything to do with the vaccination itself. It's just something that actually occurs in the population. But how many days will this take before we get an answer about that? Well, we're talking about 30 cases out of, I believe it's 20 million doses. I forget the exact figures, but it's nothing that's over and above what the type of disease you would normally expect to see in a population. So they suspended the vaccination process for absolutely no reason at all in these countries. In your opinion, there's no European consensus with respect to the suspension in Great Britain. They've decided to go ahead with it. Thank you very much. Thank you very much. In an answer that Dr. Kwok, I believe that was a written answer to question 3, you said, and I'm trying to do this quickly right now, there is some uncertainty with respect to the fact, with respect to whether or not people contract disease after vaccination. Until we have such data, we will not be able to estimate the number of people that need to be vaccinated to reduce the rate to under 1%, and we can't. Could you please explain how we can get the proper data with respect to this in case of this situation occurring? I'm trying to answer your question. I'm not sure I really understood you properly. But in terms of a symptomatic infection, this was proven in various studies. We know because other countries have looked at this. The efficiency in terms of asymptomatic infections was not good. The others didn't even look at this. So that's the case for the others as well. Now, in terms of the variant, that has no tie with asymptomatic infection and variant. Right now, in order to determine whether a vaccination is effective against a vaccination or not, we look at if we're able to neutralize the virus. We take samples from the people and we see whether it has an impact on the variant. Moreover, the other means to do this is to do vaccine efficacy studies. Has the vaccination able to prevent disease? Once again, Johnson & Johnson and AstraZeneca in their phase 1 studies were looking at the South African variants, and so we saw that the efficacy was a little bit less efficient. Pfizer did their studies before the variant came into play, but how can we use the current data to see whether we're able to control variants? We're going to have to do some surveillance of the vaccination in order to determine that. And how are you going to compile the data? They are already compiled. Thank you, Mr. Thériault.
To Mr. Davies. Mr. Thériault got a bit of extra time there, so we'll extend yours as well. So go ahead, please.
Thank you. Dr. Quashtan, NACI has previously recommended that adults over 70 years of age should be prioritized in the first phase of vaccine rollout across Canada. And we know that there's many seniors over 70 who have not been vaccinated yet. And NACI also said that effort should be made to complete that stage before proceeding to any subsequent stage as vaccine supply increases. In your view, how should the provinces and territories prioritize administration of the AstraZeneca vaccine in light of NACI's recent recommendation against use in adults 65 and older?
So at this point in time, but based on our recommendation from March 1st, because nothing else has been issued since, it's still in the works. Provinces and territories have still the ability to decide what they want, but what we had said was to try and use that vaccine in the up to 64 years of age. If some provinces decide to use the vaccine in the elderly, it's absolutely up to them. I know that Quebec has decided to use it because they have looked at the newer data, the real world effectiveness data, and therefore have decided that it was acceptable to use that vaccine. As I said, things are moving. You will have an updated recommendation within the next few days.
Okay. Now, we already heard that Canada is the only country in the world that is permitting the duration to be up to 4 months for the second shot. The fact that we're alone among all the countries in the world, does that give you any discomfort?
As I said before, I would have preferred to be within the label. However, what we decided to do here was, given the doses we had, given the at-risk population we had, was to try and give that first dose to as many people as possible.
Well, with respect, I heard that, but the issue is many other countries are in the exact same position, and they have not taken that step. So I'm just wondering, we stand alone in this one area.
I'd have to tell you, other people are currently looking at that too, and they're wondering if that's not something that they should also do. Because we have good effectiveness surveillance data, I think that, saying that we can go up to 4 months and being able to shorten that interval as needed is absolutely possible. If we didn't have surveillance data, we wouldn't have gone that way. But because we're able to do that real-time surveillance, to me, that's reassuring.
I guess my last question would be, Dr. Granville on Monday said, the most important problem with NACI is their recommendations are not always based on scientific evidence, but in some cases are based on assumptions and expert opinions. Is it correct that NACI is making recommendations based on assumptions and opinion rather than scientific evidence?
So when we do expert opinion recommendations, we do state it. It happens that we have to do such a thing. That's why we're an expert committee. The same thing when I treat a patient, I don't always have all the data, and I don't always have all the facts in the science to be able to treat that patient because it's something unique. So you have to take the data and generalize it to your patient clinical scenario. And it's the same thing here. It's something that hasn't been seen before. And so, yes, it is an expert opinion, and we say so.
Thank you, Mr. Davies. So committee, that brings round 3 to a close. I would like to ask if there's consensus to adjourn the meeting at this time. We've had a lot of great testimony from our witnesses, and it is, in recognizing the lateness of the hour, do we have consensus to adjourn? I'm seeing that. So I'd like to thank the witnesses absolutely for your extraordinary effort and time that you put in just on general principles all the time, but mostly as well, the time you've given us today and the great testimony and very, very helpful testimony. So thank you all, and thank you to the members. And with that, we are now adjourned.